The Dentalpreneur Podcast. Okay, doctor, it's time to put down that handpiece. You're listening to the show dedicated to helping dentists get their lives back. It's time to decrease your stress, increase your profitability, and regain your passion. Now introducing your host, Dr. Mark Costas.
Well, hey, DSN, how is everybody doing today? We're having just a little bit of technical difficulties, but we know how to handle such things, and we handle them by stalling. Any good jokes, Taher? Welcome, everybody. Today is the case planning blueprint, full arch strategies featuring Mr. Chris Richards, who's the executive director of the Colorado Surgical Institute, Dr. Taher Dhoon, who's the co-founder, as well as Dr. Dan Briskie, who's the other co-founder, and myself. And we're going to be talking about strategies for case planning. Right now we're waiting for Dr. Briskie to come on with the PowerPoint, and we've enabled his computer. I think when it gets to working, there it is. For the PowerPoint. Sweet. That's beautiful. I can see why that was an imperative part of this discussion today.
Yeah, I have it pulled up on my Google Drive. So I'll get us started, and then when Dr. Briskie can join us, when the technical difficulties are through, then he'll hop right in.
Okay, cool. Chris, while we have you, maybe you can kind of go over what's happening in CSI right now. We have an upcoming course next week, and then what happens after the November course.
Yeah. We've got our final course of the year coming up in exactly a week. It's going to be a really fun course. We've got a lot of full arch. We've got some single implants, some sinuses. We even have a few docs coming in for third. So it's going to be a full house. Planning about 60 total folks coming. So it should be a really fun group. The next course we have coming up is at the end of January. It's the January 30th through the February 1st, doing some more arches and sinuses, some single implants. Something that we're really excited about for this upcoming course is on February 2nd, Sunday, February 2nd. So after the live surgery course, we're going to have our first full day digital workflow workshop, where we're going to be reviewing in detail the full life cycle of the digital workflow. And we'll have industry experts, topic experts coming and speaking on pretty much every topic that a doctor will need to know to either establish their digital program or to continue to refine it.
Awesome. Fantastic. So how many courses do we have planned for 2025, Chris?
Right now, we've got 6 courses planned.
Okay. The digital workflow course is tacked on to another surgical course, or is that a standalone?
It is attached to a surgical course weekend, but it's a standalone event. So doctors can come through the surgical course and stay, or register and stay for the digital workflow, or just come to the digital workflow itself.
Awesome. And Dr. Dhoon, any updates on 2025 dates for IV sedation?
So the cool thing about IV sedation is that you can sign up ahead of time and do the first or second part of the course virtually. And then when you come for your third and fourth, where it's your live patient reps, then we tack that into any one of the surgical courses. So we try to get you reps on wisdom tooth patients, single implant patients. And of course, we set up a few slam dunks where it's just a really quick procedure. And so the big difference with that is, typically IV sedation courses are going to give you reps on like prophy patients and class 2s, where you're really not deeply sedating anyone for a long period of time. And then in this situation, when we get to tack you on with wisdom teeth and single implant cases, and you have to keep them sedated and comfortable for those types of cases, you actually get like a real world experience with it. So we're going to, any attendees that come in, we put them into different surgical courses that are taking place in 2025.
Cool. Awesome. Well, great. All right, guys. Thank you for the update. Dr. Dan isn't on yet. So Taher, why don't you, since we have the PowerPoint pulled up, why don't you start us off here and let's start talking about case planning.
Okay, you got it. So first and foremost, I mean, if you don't have a CBCT and you're doing implants in your practice, I don't necessarily think you're, below the standard of care, but if something legally does pop up, you really need a CBCT these days. So nonetheless, we're going to say, look at the CBCT from the start. If you're doing full arch, you need a CBCT. There's no doubt in my mind that absolutely is the standard of care. So what we do is we're actually going to draw on the CT. This is what we do in our consultation room with the patients. In the Vautech software, we can just, draw on here. So I'm going to trace out the sinuses. I'm going to show the patient where the base of the nose is. I'm going to trace out the sinuses on the other side. I'm going to show them where the bone levels are. Mark, can you see my cursor?
I can.
On your side?
I can, yes.
Okay.
Mm-hmm.
So I'm actually going to trace here, and I'm going to say when you were 12, the bone levels were here, and now the bone levels are here. And then the same thing down here. When you were 12, the bone levels were here, and now they're down here. Mm-hmm. So I'll trace out the nerves and all of the above. Then I like to generate it in the CBCT, because with the CT, the patients now can see the technology that you have available to them, and then we plan out the CT. Mm-hmm. Ideally, I like 6 implants up top and 6 on the bottom for full arch. Now, there's a lot of docs out there who are saying 4 implants up top and on the bottom is absolutely adequate. And there's 2 philosophies on this. So if you have 6 implants up top and you're kind of in the beginning of your career with full arch, I think it's better to have 6, because if one fails, then you can remove that one. You can still have the patient wear the same prosthetic, and then you can graft and you can, manage the case a little bit easier. And sometimes if you lose an implant, you don't even have to, change anything. You just remove the implant and keep pushing forward. Where if you have 4 implants, if you have one fail, well, then you got to replace the thing, you got to remake the prosthetic. There's a little bit more difficulty with managing those cases. So nonetheless, all on 4, all on 6, whatever works better in your hands, absolutely is tried and true and proven. But from a Colorado Surgical Institute perspective, when we teach, we like to have people do 6 implants just to have a couple extra redundancies in place to prevent, headaches later down the road.
100%. Understood.
And then you got to execute the plan, right? This is a case that Dr. Briskie did. This case, I think you could plan for pterygoids. You could maybe not do pterygoids, but at the end of the day, it's a nice spread. Let's imagine that this pterygoid implant here and this pterygoid implant here isn't there, and you gave the patient 1 molar distal extension off of that distal implant. Same thing, 1 molar distal extension off the distal implant. I think that's absolutely adequate. I think that's a great service for the patient. Once you get further in your full arch game, you can incorporate pterygoids and other things later down the road, but it's not something you need from day one. I'd say at least have 50 arches under your belt before you think about pterygoids and planning from that perspective. So some things to consider, like every case in the beginning, I got excited. I got really excited when patients said yes. And I would start doing cases that were pretty darn difficult. And then I hit a snag where I had more failures and it affected my confidence. So we want to talk about ways to refer so you have more success in the beginning, which this just has the positive feedback loop for you and your team to see success in the practice. And then you're going to do more cases. So big pneumatized sinuses. I'm going to go back a screen here just to show you. So this is where the sinus is here. And if that distal implant can come out of the second premolar, you're good without pterygoids.
One more time. Can not everybody can see your cursor, Taher? So can you talk through teeth numbers and the slight angulation that you're talking about? Got it. Okay. Yep. So where the sinus is in relation to that distal implant on the left and right side in the maxilla, if the sinuses had come in a whole nother tooth. So if the sinuses were mesial, a whole nother tooth, and my implant can't come out of the second premolar, then at that point, I have a shortened arch. So a general rule of thumb is you want that distal-most implant to be coming out of a second premolar for that upper arch to have a proper AP spread. If you don't have that, then we're going to say the sinuses are pneumatized to the point where
you need to consider either sinus grafting or pterygoids or zygomas or something else. So if the sinuses are very large, then at that time, maybe you refer that case to someone else who can manage that type of a case. Also, you have this hourglass shaped mandible. So we've all seen in the CT, it looks like an hourglass shape, where via 2D, there's a lot of length to it, and it seems like a very easy run-of-the-mill case. But then you get this big hourglass shape in there where there's a concavity, or you got a submandibular fossa that's like just really prominent. Those are like horrific cases to do. So you really got to look out for that. High smile lines. This one caught me left and right in the beginning. It used to really cause problems. So what's going to happen is the patient is going to smile and they're going to show a lot of tissue. Those are cases you do not want to do, or you have to approach it via an FP1 approach. And then also your D4, D5. So this picture here is going to depict what a D4 and D5 case looks like. So you got that cortical shell on the outside, and then you got your D4, D5 bone inside. Those are the ones where your implants go in and it's just like mashed potatoes in there. They just start to float around. Crazy patients, we all know. And welcome, Dr. Briskie. Just saw you got the computer figured out.
Hey, Dan.
Yeah, I had DSM webinars are like one of my favorite presentations to ever do. I had everything open 10 minutes before. And then while the Zoom was opening, it crashed and then my computer made me restart. I'm like, oh, this is fantastic. So sorry, guys.
No, you're fine. Not due to lack of effort at all.
No, I'm sorry. So yeah, this case right here with that picture with the D5 bone, I only had 3 spinners last year, 3 implants that I wasn't able to get stability on, and that wasn't one of them. It's just absolute mush. I pushed a burr in, and then I put a 5x8 in, and then I put a 6x8 in, and I got like 10 Newton centimeters. Wow. So it's like some of them, no matter what you do, you just won't get stability. But I would argue that that percentage is still very small. Mm-hmm. Mm-hmm. And for pterygoids, what cases need it? So if you're doing fixed full arches, I don't recommend anyone to have a distal extension that is over 10 millimeters or more than 1 tooth, unless you're doing a big bar. But bars are more expensive. So when you are doing bars, make sure you have to add that into your expense as well. And you have to predict where your last implant is going to come out. So there are some cases where you should be planning that eventually this case will need some pterygoids. You may not be able to do it yet, but you will someday.
Mm-hmm. One thing I'm doing in my consultations is I'm prefacing the patients with the need for future treatment. So I want them to understand that when you do this case, in the future, you may need gum grafting. So I tell every full arch patient, hey, right now we're going to do your surgery and everything is going to go great. But in the future, you may need gum grafting. So in 1 or 2 years, sometimes 3 or 5 years, we might talk about gum grafting. So I'm prepping them for that. So if you're not doing pterygoids and it's a case that might need pterygoids, I would also prep them with, hey, in the future, you might need a couple extra implants. That's a conversation for another year. But my job is to look into the future and make sure that I don't surprise you with any conversations that you're not prepared for.
Mm-hmm. Excellent.
So this is a case where you see how the pneumatized the sinuses are. Mm-hmm. And it's like, how are we ever going to get this patient a good result without having to do some sort of big sinus lifts or needing pterygoids at that point? So if you just place an all-on-4, your last implants are coming out the backside of the canine. So your screw hole axis is going to come out the first premolar on each side. Mm-hmm. So your distal extensions to get to a first molar is going to be pretty lengthy. You got a molar and you have a premolar to deal with. So spotting these cases ahead of time and saying, do I maybe want to present a denture for now or present this one, and just don't get yourself into trouble. I would used to say yes to everything, and you get yourself into trouble because you try to squeeze stuff in and then you wish you didn't do that later. Mm-hmm. This is a case I did about a year and a half ago. I did lateral sinuses and I went and placed the first 4 implants. Then I went to place my 2 back ones and it's just absolute mush. I was like, this is not going to work. Didn't get any stability, maybe 5 Newton centimeters. So I pivoted into doing some pterygoids. Like, luckily I was able to do that, right? If you didn't do that, that's okay as well, but you'd have to bury those shorten the cantilever quite significant amount of time, and then come back for the second surgery to add them later. But is this type of case very predictable? Not really, right? Because if you have to do giant lateral sinuses, there is still a chance that it doesn't work out. So I had this case right here. This is a very thin hourglass mandible. This is on one of my best friend's dads. So this one, this is really awesome Romanian guy. He doesn't speak a ton of English. He's like, Dan, you got this, right? I'm like, yeah, sounds good. Like, little does he know that he has a 10 out of 10 hard case. There's just such limited bone, and the bone he does have is so thin. I have to just barely squeeze implants in. But what happens when you squeeze implants in is bone can break, or you can actually get a lot of bone loss. If you get bone loss on one of these implants with an hourglass mandible, this is a catastrophic failure. So trying to just squeeze implants in, I used to do that, try to squeeze implants in a ridge that was 5.5 millimeters. Then I would get some failures and I didn't know how to recover from that. So same thing, please everyone be smart with your case planning, maybe not try to squeeze them in like right away.
Yeah, on cases like this, if you're in a situation where you want to take this on, graft it first. When the tissue is that thin and you need to graft it, you're probably going to need soft tissue grafting as well. So you got to plan the patient for 3 different surgeries. All right, you got the bone augmentation, you got the soft tissue augmentation, and then you got the all on X or whatever surgical approach you're going to take. And then you got to look at it from the stance of like, okay, is that really worth your time to do it? You know, if you can say no to a couple of cases in the beginning, this is one of the ones where it's really good to say no to it.
So this is the case I did. I squeezed 6 implants on the top and 4 on the bottom. As you can look on the image on the lower left side, there's not much room for error, right? We barely have our 1.5 millimeters of bone on each sides. And it's the same on the top where we barely have that 1.5 millimeters, right? So you have to make sure you drink your coffee that day. Thank God I had no implant failures with this guy. Otherwise I would have been an enemy to the family there. So what to consider, what are the restorative options, right? Are we going to do full arch? Are we going to do overdenture? How many implants do we need? Can we over-engineer this to make sure this patient has teeth until they're 95 years old, which is the average age right now? How much bone removal do we need? We're going to chat about that next. Where are the locations of the implants going to be? Where will the most distal implant be, which is very, very critical. High smile pre-op photo. That's the most important photo you can get, is having the patient just smile as big as they possibly can. So you can look at the amount of reduction you need. Having the proper implant stock. What implants do you need in stock to anticipate issues from happening? Plan your implant on the CT and then execute your game plan. So I think a well thought out game plan is one where you put the implants on the CT, you anticipated the problems that were going to happen, and then you executed your game plan, and your CT from before looks exactly like the CT after.
And one way to get a high smile line picture on patients who haven't smiled for decades is you can sometimes ask them to close their eyes and smile really big, because sometimes they're just habitually programmed to not tense those muscles up. So you really need to get that high smile line picture, and you keep that picture up in the operatory when you do your procedure so you can keep referencing it.
So generally, with monolithic zirconia, so without tie bases or without bars, right? So this is just one solid piece of zirconia. The minimum thickness can be 10 to 12 millimeters, right? So you get a lot of freedom here because you don't need a ton of room for the restorative. Before the surgery, what I start doing is I start planning the estimated reduction. You're not going to know the exact amount, but what we can start making some general assumptions based on if the patient needs the vertical open or if their vertical is pretty close. I would say in 90% of my cases, I'm reducing 4 to 5 millimeters of bone. Dhoon, how much bone would you say you reduce in most of your cases?
Yeah, usually around the same. It just really depends on what the Mossad ruler is measuring for me. And so I'm a big proponent of using the Mossad ruler mid-surgery. But a general rule of thumb is you're going to be reducing, like Dr. Briskie said, 4 to 5. There is a movement in the industry towards conservation and preservation of native bone. Mm-hmm. So just know if you're aiming for 15 millimeters of thickness for the prosthetic, it's not antiquated, but it's just an older thought process that we're now kind of moving away from and making prosthetics a little bit thinner to set up the patient for a secondary surgery in the future.
So I always encourage everyone to not reduce the bone to where the patient has 10 millimeters or less of vertical bone height. So if you have the option to graft versus reduce all the bone and leave the patient with 10 millimeters, I would choose to graft it because you have to think later down the road. So I'd never want to just remove all the bone to kind of squeeze and implant it. That's my personal. We can open the VDO using a VDO gauge and leaf gauge. I want to show you guys a picture of that here shortly. And the Masad ruler, just like Dr. Dhoon was talking about. And generally, we're going to want to measure after we take the teeth out, after we flap, how much bone we have from the crest to the resting lip position. And make sure you don't, like pull the lip down to measure this. You want to make sure that it's passive. So the lip wants to just rest on the ruler.
Yeah, and we get a lot of questions about this after the courses. So I recorded a video of the Masad ruler getting used, and it's under my Instagram handle. It's just at Dhoon Taher. I didn't think of anything too witty or catchy. So it's just last name, first name. If you look it up on Instagram, I just have videos of surgeries, and I have a good one of how to use the Masad ruler.
And here's a picture of the Masad ruler right there on the right side. And the other one is for the VDO gauge. And Dhoon, is there a way I could get access to control it? I can't really click anything.
It says you're controlling my screen. So this is Dr. Briskie's implant stock in his practice. It's a good way to keep things organized. I don't like the way I do things in mine. I kind of have it all like stacked up and it just floats there. So when I grab stuff, things get all kind of tilted. So this system, it looks very slick and clean. Probably helps you keep inventory dialed in pretty well. Are those just like bookshelf separators?
Yeah, there's little bookshelf separators, and then I stack them into this big cabinet. So when I did my startup, I had this giant, like this really big cabinet in my surgical operatory, and I store everything in there, and it's lockable. So drugs can go in there, implants go in there, surgical kits go in there, everything. And I like to stack my implants because I have a very key inventory that I keep. I have like a very specific plan. Like 90% of my cases, I place a 4 by 11.5, and I place 4 3x13s, and I place a lot of 5x8s. So I like to keep my main sizes for my surgical plans, and then I anticipate needing to go one size down or one size up, and also one size longer in some cases. So for every implant that I'm placing, I want to make sure my brain says, okay, well, do I have these other 3 options, right? If XYZ does happen in the surgery. So I know Mark might cringe seeing 50 implants in this cabinet here in terms of my overhead numbers, and I agree. But for some of these cases, when you're doing 6+ arches a month, you do need to have an inventory to make sure you do not have any patients that are leaving with a denture. That every patient gets loaded. But for the most part, for anyone that's listening, I would supply a 3.5 by 13, a 4.3 by 10 millimeter, and a 5 by 8. Those are really 3 common sizes to keep in your practices. If I would have to pick any sizes, I would pick those.
Yeah. One thing I would say, Dan, is that, this would be considered a kind of a one-time bolus cost to get the inventory up. So if you're evaluating a practice or you're actually calculating your EBITDA, you can remove that as a one-time expense as you normalize your P&L. Not to talk about business right now, but what also makes up for this huge inventory that you have is the fact that you have a method to it. And it's not just like, hey, I got a 20% deal, so I'm going to overpay and with no rhyme or reason. So I think that there's a rationale behind what you're doing there. And also your organization makes up for a lot of overspending in my book, just because it looks really, really pretty. And it actually scratches all my itches for my OCD. So it's beautiful.
I love that. It scratches mine too. I can open it. I'm like, all right, do I have what I need every week? And it's easy for my DA because they're like, I know my supply.
Yeah. At a glance, right?
Just reorder that one implant.
Yeah, just like tip out bins. At a glance, you know what your inventory is. I love it, dude. It's pretty sweet.
Yep.
Yeah. And the one thing that Dr. Briskie talked about was the 5.8, the 4.3.11s, and the 3.5.13s. If you look at the surface area of those three implants, they have about the same bone to implant contact. It's called the BIC. So it's the same bone to implant contact on a 5.8 as a 4.3.11.5 as a 3.5.13. So that's kind of why we use those implants in a higher volume than maybe some of the other ones.
So it's important to, so Dhoon, you'll have to go through the slides. Mine still doesn't let me do it when I do it. Okay.
Yep.
So the main thing is you plan something, and go ahead and click the next one, and then you execute it, right? And like when I do something like that, when I look at my plan before and I look at my plan after, it looks the same. I get so stoked. I go back to my computer, I take the CT, I'm like, yeah, like that feels good, right? That feels like I'm back in high school or college playing some soccer and you just scored a goal, you know? And go to the next one. So the first case study is going to be Phil. This guy's a patient of mine where he doesn't have a vertical change. So it's important. I want to start off with a case planning where we don't have to change the vertical dimension. So how do we do an upper lower case? This patient's dentate and not changing the vertical. So this is where he came in. Again, I always tell all my patients, I like to scribble on the CT. I show them where their bone is, where their sinuses are, where their nerves are, and where I can place the implants. And I tell them, hey, good luck for you because you came to me. I'm cheaper than the big guys, and I also place more implants. So therefore, you should sign up with me. I'll place 6 instead of 4, and this is where I'm going to be placing them. And patients really love that. Like, oh, how come my last dentist was only going to place 4? I was like, well, Phil, you need 6, and then they sign up. So make them slightly paranoid to go to anyone else besides you is one of my tactics.
Yeah, I'm going to go back one slide real quick. By the way, good photography on this one. When I look at this case, I see he has an abundance of keratinized gingiva. Like, that's a lot of kg. So that immediately makes me feel better about the case. And then 2, super constricted maxilla, right? Super constricted maxilla. So it's probably going to be a really high vaulted maxilla. So you don't want to make an arch that's really narrow. You want to make sure you expand it a little bit. And when you see a constricted maxilla like this and bruxism, you might have to look at airway, because if they're not breathing properly at night, they're going to be grinding and clenching. If they're grinding and clenching into your brand new implants and temporary prosthetics, it's going to be a lot of broken prosthetics, a lot of loosened screws, and a lot of like heartache. So you got to figure out ways to make sure that when you evaluate your case, you're starting to just, register some of the risk factors before you ever get started.
So here's my game plan. I plan 6 on the top and I'm planning 6 on the bottom. All my surgeries literally look the same. So I think a lot of time when we go through these full arch classes, docs will look at me and they'll say, hey, like, what do you mean your cases look the same? I'm like, they actually really are. My planning is the same. You start to see like a recipe for our madness. I always put 4 between the mental nerves, and then I put 2 in the back. That's always my strategy for the bottom. For the top, I will usually place my most distal implants first. If the sinuses are slightly pneumatized, then we see how many we can fit in the middle. So 2 in the back, and then sometimes 3 between the 2 implants, and sometimes 2 between the implants. Now, if the sinuses are not very pneumatized, all right, kind of like this case where you can still fit a couple implants in, I'll put my back 2 implants will be at the first molar, and then I will place my distal implants at about the first premolar, and my front ones are at 7 and 10. So it is 2 different strategies, whether the sinus is very pneumatized or it's not very pneumatized. So if it's not very pneumatized, my back implants would be at a first molar. If it is very pneumatized, I'll focus on placing my most distal implant, which is usually around the second premolar. And I'm going to click on that video. So in every single case, we get an upper, lower, and a bite. So this case did not have to have a vertical change. So you get a trio scan of the top and the bottom and the bite. And the bite is going to be where we want to have it at the end of the case. We used our VDO gauge and we measured, and he was spot on with our VDO gauge. So go next slide. So every single case needs a full set of photographs. You need a forced smile. That's very, very critical. An intraoral scan, you need upper, lower, and bite. Still my favorite scanner to this day is the Trios. And the scan has to be in the correct VDO. So if you need to change the VDO, your scan has to be taken in that. So you're going to spoon feed the designer who sits on his computer and makes the teeth the exact vertical you want. So you can't just write in your script, hey, open up the vertical 4 or 5 millimeters, because the joint is a hinge. You don't know what direction the hinge is. Like, does it open like this or this or this? You don't really know. It's not reproducible on a digital articulator. So you're going to hand the designer the exact vertical. Optional, I do think face scanners are optional. I think a photo can onlay the teeth just greatly. This photo has what's called a software planning called Exicad. And this is a preview of what his teeth are going to look like, which I'll show you next. So his photo gets stacked on the digital design of him. So I can see where his smile is and if I want to change anything. And next slide. And this is a video of the pre-surgical workup. So after I send my designer the upper lower bite, they're going to wax up teeth and they're going to put it on there. And you can manipulate it, look it around. Do I want to add some teeth, subtract some teeth? You can start looking at things like, is my prosthetic thick enough? Do I have 10 to 12 millimeters? And even if you look inside that design, you can see where the teeth are going through the tissue. That even helps you approximate how much reduction you're going to need, right? Because you can look inside that and say, oh, is that about 3, 4, 5 millimeters? And that helps you get your adequate thickness. So it gives you a really good game plan. So I encourage everyone, when you're doing a workup, make sure you do this workup about 2 weeks before, so you have plenty of time to just look at the scan, look at the CT, look at your Exicad preview, and start looking at common trends of where your implants are going to go and how much reduction you need. Yeah, and it all gets stacked on an image, which is cool. Go next one. Now, what records do we get the day of surgery? So before the teeth are removed. So before the teeth are removed, I start to put a few TADs in the tissue. And what that is a TAD is just a fiduciary marker. It's a marker which is going to stay consistent. And once the marker goes in, you take the teeth out. So you're going to need to be able to stack the images together. The designer is going to want to put this image and mesh it with the first image, which is the one with the teeth that you initially gave him. Now, after the surgery, the TADs are still in there. So what the designer is going to do is we're going to get a soft tissue scan now. And our markers on this case, where the designer is going to mesh the scan from before to the scan after, he's going to use this scan because the TADs are still in there. And there's also a second molar where the designer can mesh the two scans together. And then you get something like this. So this is day of surgery. I pull this up. This is a preview from the designer. And he says, do these teeth look good? Can I proceed with the final? So here's the teeth from before. And then if you look inside, you can see the TADs there. So what they did was they stacked the images together. They overlaid them. So now they know where the teeth used to be, even after the teeth were taken out.
And just make sure in your TADs, there's no dried blood in the crosshair. It needs to be clear for the design to mesh up properly.
And then we have teeth. And this is how we make sure that we don't have any adjustments, right? The data needs to align properly. That's also why I really like using a good scanner, like a Trio scanner, because it will align the data nicely. You'll be able to get a scan without introducing a lot of error. So a lot of practice still tell me hey, I'm going to use my iTero. It can work. It's just going to take a lot longer, and you may have to do another set of temporaries to get your bite. So you may have a little bit more adjustments. So I like using a scanner that's not going to have too much adjustments at the end.
And what I was doing before we had a Trios is I was taking a PVS impression and we were scanning with the Medit outside the mouth later down the road. So if you're not up for buying a brand new scanner, you can always do a PVS impression and then keep moving forward, because you don't want that scan to take you 20 minutes using an iTero. So you do a PVS, and then you have someone scan it outside the mouth as you keep working to keep your surgical times lower.
And here's after. So this is day of surgery. So we got some nice teeth. The surgery was the same. So I planned it. Where I was going to put the implants are the same on the top and the bottom. The teeth look pretty nice. I felt like this was a good win and a successful game plan. Mark, any questions on that case at all that you think we could answer?
No, I think you guys are doing a good job. I am a little bit fuzzy about Dr. Dhoon's strategy with the IPS impression to keep the surgical time down.
Yes. So what will happen is if a scanner isn't very good at scanning the soft tissue, Dhoon, can you go back to the slide with the soft tissue?
Yep.
Go one more behind. That one. So Mark, imagine a scanner on the lower arch specifically. Usually scanners are very good at scanning an upper arch because it has the palate. Now the palate's not there and we're scanning the lower arch. It's very hard for a scanner to know how to stack the images together or go from the right side to the left side without creating double images. And what happens with a lot of scanners like a Medit or an iTero, a lot of them will just keep creating double images and you can never get an accurate scan.
Got it.
So what Dr. Dhoon will do is, when he used to have the Medit, was he would take an impression of the lower arch and scan it outside the mouth. That way he's eliminating the lip and the tongues and any source of error. So his scanner is more likely to scan a PVS impression than it would to scan the blood and saliva in the mouth. And that's how he's able to get a better and more accurate set of data.
Got it. Awesome. Thank you.
And the second case, I want to show everyone what it would look like if we did a case with a denture. Like, how do you do with a denture now? So this patient, John, he has an upper denture. So I made him a new milled denture for the top. And for the bottom, I took his lower denture and we're going to do an all-on-4. So he had no bone behind the nerves. So we have 4 implants. This one is a true all-on-4. I can't squeeze another 2 in the back. So what we do on the day of surgery, we scan the denture. This is in his mouth too. So it's an upper, lower, and bite. And he needed no changes with his vertical. His last dentist made him a very nice set of dentures. His upper denture fit fantastic still. So we only did a lower arch for this one. So now let's move to the next slide and we'll go over that. So this is a workup of the lower arch. And if you zoom in, you can see where the teeth are. So the designer added teeth from the denture scan and the soft tissue scan. So you can see even with barely removing any bone. So in this case, if you peek inside, see how to get that minimum thickness, you need a few millimeters, like 2, 3. And that was my surgical plan. In every case, I only do a first molar, just so everyone knows. I only do first molar, whether it's on the top or the bottom is my goal, because too much of a distal extension, you can break. Also, if you're placing implants at second molar, you have an increased chance to not have enough reduction. So I always encourage everyone to only do a first molar occlusion when you're doing all nexus.
And if patients ask for a second molar, tell them it's an extra $10,000 to get them second molars. And then at that point, they're like, oh, okay, well, don't worry about it. So just making sure that you address things in the consult room versus when you deliver the final is going to save you from some tough conversations.
Yeah. Let's go next slide. So records the day of surgery. So we're going to put the TADs in on the day of surgery, and then we're going to get a scan of it with our intraoral scanner. And then we're going to send that to the designer. And then we're also going to take his denture and reline it with a light body wash. And then we're going to scan that as well. So see, that one has the hexes in it, has those 2 TADs in the back. So we're going to send both of those to the designer so he can start stacking the data together. So now he has the denture from before, and he can align it to the tissue of the day of surgery. Now we have the surgery done with my 4 implants. And now we get a scan of that. So the designer can mesh the one from before surgery with the one after. So he knows exactly where to put the teeth. And this is our result. Pretty good first molar, good distal extension there, less than 10 millimeters and less than 1 tooth. So 1 tooth or 10 millimeters is still my rule. Mark, any questions on that type of one at all with the dentulous?
That was a really good one with what to send the designer and how the designer's going to use those 2 scans.
Yep.
Yeah, that was a good one. Thank you.
So here's another one. I want to show this third one as a bone excess case, a bone excess, and it has needs an increased vertical. And this picture to the left is a really important one to get. You want to get one with a really big smile, right? Because if you get a patient, you don't have them a smile, you have no idea how much bone to remove. So you kind of make them laugh. I told him pretend it's your wedding day, you have to smile, because his wife was in the room. So he smiled really big. Otherwise he'd be in big trouble. Let's go to the next slide.
Yeah. And the one thing I want to point out about this one is the patient's upper left lip goes up higher than the right side of the lip.
Oh, yeah.
So you watch for these asymmetries, because you'll sometimes get caught where you hide the prosthetic in one area and then the lip tenses a little bit asymmetrically somewhere else.
So here's his case. Not the highest sinuses, but he needs a lot of reduction, right? He needs about 4 millimeters at least, maybe almost 6. And he had all his teeth. This was actually the most difficult extraction case of my entire life. This double arch took me 6 hours.
Whoa.
And that was like crazy. And this was for me, and I did the surgery 4 months ago. So I was sweating the entire surgery, just trying to get these root tips out. He's got like D1 bone, like really not much PDL ligament, and everything was just fused. And I actually, for the first time in my life, Mark, I pushed a root tip into the sinus.
Oh, this is the guy. This is the
first time I've ever done it. And I was like, I thought I was going to get way further out in my career. I thought I was going to get to like 1,000 arches before I did this, but I finally had my day. But a day finally came.
Wow. How did you retrieve it?
And go next slide.
Did you retrieve it, Dan?
I did. I went into the sinus and I grabbed it.
Okay.
Yep. So this is my pre-surgical plan. And where the implant was going on the upper right was where the root tip went up. So therefore I was not able to place my implant there. And next slide. So what are the surgery records we get in this type of case? So this one, we know, man, look at this guy. He just destroyed his teeth. We need to open up the vertical. So I put a leaf gauge in. I opened up about 6 or 7 millimeters. You don't want to over open them too. So I start thinking, all right, what's the max I can get without really making too drastic of a change as well, right? The patient needs to adapt a little bit to this. So I opened up about 7 millimeters. And next. Records do we get the day of surgery? We're going to get same thing, right? We put our TADs in. We got a scan with the teeth in, and we get a scan with the TADs in, and we send it to the designer. Same thing for the bottom. And then afterwards, we get a scan of the soft tissue, and the TADs are still in there, right? So upper right, that's where my game plan did not go to execution because I pushed a root tip up there. Right?
He looks good.
Man,
really good.
I was really anxious to see the post-op on this one. This one looks good. And that's funny that you mentioned his asymmetry there, Dr. Dhoon, because it's very prominent in the post-op.
Mm-hmm. And I can see, I can tell those extractions were hard. I've actually never heard you say that before about a case.
If you look really closely, I'll admit I actually left the root tip there on the wisdom tooth.
Right here. Yep, I can see that.
Yeah, I reduced the bone down to I removed the enamel and I left it there. Yeah. And I couldn't get it out, and the patient was waking up. So we did basically coronectomy. I left the root and we took all the enamel away. So there was and we're at our 6-month post-op already, and there's no issues whatsoever with sinuses or anything opening.
I really like the fact that you shared a case you struggled on. Mm-hmm. Because sometimes people think that because you do a lot of surgery, you're just infallible. And it's like, some cases are just really, really hard. And 2, it's like, move on, leave the root tip, finish your case. Like, don't exhaust yourself to the point where you can't do the rest of the surgery properly. Leave it, come back, fight another day. If the root tip's bothering the patient, go in there and grab it later. This is a good one.
And next slide. So here's one more. This is one that needs pterygoids that we're going to talk about. So one that I would recommend it. This one's Ken. That was his 4 smile picture. Still very important. So when you look up this workup, you don't have the best extension here. So your upper right side, the most distal implant based on his bone, because the bone got extremely narrow right there at the first molar and second premolar, it's going to be coming about the first premolar. So the distal extension is going to be a little too long, and you're going to want to either do sinus lifts or you're going to want to do pterygoids. And next slide. This is my pre-surgical workup. And why the pterygoids, right? It's because just like I was saying with the distal extension, I really didn't think I could get this to come out at the second premolar or have a cantilever of less than 10 millimeters. So this type of case, you would definitely need to plan lateral sinus augmentation or to do pterygoids. This is the post-op afterwards, or the day of surgery. Really good spread now on everything. And this is his 1 week with a smile. This is one of my favorite ones. I really liked his smile after. He just looks so much better. Looks younger. Only a few weeks apart for his photos.
The first picture looks like he's like in the gold rush from back in like the 1800s. and then he looks like he's like back in regular society with the art.
Yeah, right.
Hey Dan, if I don't want to take too much time here, but if you go back to the post-op scan. So I'm looking here, and because you have 4 on the bottom, could potentially a cantilever have been done on this one with 4 on top? I mean, it's not going to give you... It
actually could. I got really good spread, more than I thought I could have achieved.
Yeah, right.
I could have gotten away without it. And then in my surgeries, I'll look at my assistant and I'll look at him like, should I put pterygoids in?
Yeah.
Because you'll look at they're like, then we look at the time and we look at the spread and we're like, where do we think this is going to come out? Right. Mm-hmm. That's the biggest question. Because if those came out at the first premolar, you really need something in the back. So nowadays I will be a little bit more safe by placing the back ones in there.
Got it.
But you could have definitely gotten away with a tie bar for the top with an all on 4.
Right. Okay.
Yeah. And then also, Mark, these are coming out the second premolar. So technically, because he was able to get such a good spread, you could just give the patient a first molar on either side and be totally fine. But also if the patient's a grinder and bruxer, then sometimes in the maxilla where the bone is softer, you want that extra, negative AP spread or better AP spread up top versus needing it in the mandible.
Dhoon, can you go back one slide to the pre-op? To the game plan one real quick. Let's see. Oh, right there. Yeah, perfect. So Mark, I want to show you something that we get a lot of questions on. And if you look at the upper right and the upper left, do you see where the sinus comes down?
Yeah.
Now, sometimes we underestimate the amount of reduction we need, right? And we have to remove more bone. But if we're removing more bone around the sinuses, guess what happens to our most distal implant? The more we reduce the bone, it gets constricted, goes in. So we could have thought that our most distal implant was at a second premolar, but by the time we reduce the bone, the sinuses are creeping in, and now all of a sudden our most distal implant is at the canine. You're like, oh my God, what happened here, right? So I would really encourage everyone to not get stuck by over reducing by accident, right? So use the general rules that we have and that we teach, which is usually max 4 millimeters, and using the dental slip ruler. Over reducing is not always good. Right? To have that prosthetic space is great, but you still have to protect yourself from accidentally removing too much bone and constricting the implants to be where now you need pterygoids or lateral sinus lifts.
Yeah, that's a great example of that domino effect with, one decision that leads to difficulty 3 steps down the line. And the whole prosthetic kind of plan can just kind of go up in smoke if you over reduce. That helps a lot.
Okay.
All right.
So that wraps up the presentation. I mean, if anyone has any questions, we got a few minutes that we can dive into it.
We got 7 minutes. If anybody has any specific questions, we had a really nice turnout with the people that are showing up live here and in DSN. So if anybody has anything, we can field questions for about 5 more minutes.
Yeah, from a case planning perspective, for me, the biggest thing is the consultation room these days. It's really managing expectations and saying things in a way to the patients where talk about the complications, talk about the difficulty in some areas, and then talk about why you're qualified to handle it too. Because I think if they go to a lot of places for second opinions and they only hear the good, and then they'll come to you and we'll be like, okay, well, yeah, you're talking about some of the problems that might arise too. If you can look into the future and talk about some of these potential scenarios that they're not aware of or no one else has told them about, you're immediately a little bit more qualified and more of an authority in their mind, because you have the courage to kind of educate them on the pros and cons of the procedure. So I feel like case acceptance goes up when you start to really truly educate them on some of the obstacles as well.
Yeah, you take their plan, then you say, well, will that get you to 95 years old with teeth? Right? And then you're like, well, Dr. Dhoon's plan is this. This is how Dr. Dhoon will make sure that you have teeth now, but he's thinking in the future, if you ever need a potential second surgery, or how do we actually get you teeth forever? Right? That's the most important part.
Yeah. Really good presentation, guys. Appreciate all the effort you put into those images and that deck, Dan. That was really, really good.
Thanks, man.
Okay, I think that's it. Ashley, do you have anything as we wrap up? Any reminders or how to get continuing education credits for this lecture?
Yep. So if you check out the chat, there is a link where you can go ahead and fill that out. We will give you 1 hour of CE for your time with us today. And then also, I know we have several people here who actually aren't DSN members. Our DSN members get discounts to courses like CSIs, and we are constantly having more webinars. You can get the access to the recording if you're a DSN member. It is in the webinar section inside of Workplace Chat. That's where we have all of our recordings too. So if you're needing to access the recordings, then sign into DSN or join with our 7-day trial link in the chat as well.
All right, my friends. Thank you, everybody, for being here live, and all of my friends inside DSN. And, of course, Ashley, Dr. Dhoon, Dr. Briskie, and Mr. Chris Richards. Everybody have a great day. Good to see you.
Too. Thanks, Mark.
Nice. Thanks, everyone. Appreciate you. Thanks, Mark.